All right, so filming this today, which is day 3 post first round of chemo. But basically, I want to take us from where my last video left off, which was a diagnosis and a visit to the cancer surgeon, um, to day 1 of chemotherapy. So, what has happened in between the end of finding out that I have HER2 positive breast cancer, and now um, initiating treatment. Obvious sort of elephant in the room. I did dye my hair blue in anticipation of losing it all. And I've got some clips and footage, and I think I want to sort of put a separate little thing together, sort of documenting the hair dyeing and loss and maybe regrowth journey associated with my chemotherapy. But right now, I'm enjoying this sort of turquoisey blue sort of fun hair color. Again, for those of you who might not know, I'm Sarah. I'm 35 years old. I'm a wife and a mother of 3 boys. I do have a PhD in biochemistry and molecular biology back from my, it seems like a lifetime ago days. But I am not a medical expert, so please, I'm talking through my breast cancer story and journey as a way for me to process it and as a way to make my story accessible to other people that might find help in my sharing it, but not in me giving any sort of medical advice or judgment or anything. So, disclaimer out there. Some of the comments on my last video were that I presented things in a very educational fashion. That comes from my background in science, but is not in any way to be taking anything from me, that you should be, listening to your doctors and your medical experts. That is not me. This is my story, my process, and putting things down in some notes before filming a video and then sharing with the world and with YouTube is something that I think is going to be helpful in my story for my process. And again, hopefully for other people. I do also want to say a huge thank you to everyone who commented, everyone who's found me through my last video. I posted it very specifically on the day that I went for my first round of chemotherapy, in addition to some social media posts over on Instagram. And I can't really express enough how much that constant flow of positive comments, of good vibes, of well wishes coming in throughout the day, how much that made my first day of chemo a much better experience and a less scary experience. So thank you so much for all of your kindness. I really appreciate it. Where we left off, my last video ended with seeing the breast cancer surgeon with the anticipation that we would be meeting with the oncologist shortly and that we would likely be looking at some chemotherapy, surgery, and additional chemotherapy, but not really knowing much of what that would look like specifically in terms of the specific drugs. We assumed Herceptin, and I'll talk more about that later just because I do have a HER2 positive breast cancer, but we didn't really know much else. Additionally, we did not have any sort of concrete staging completed yet. Where we were was that it appeared to be confined within my breast, but we were still waiting on a bone scan to sort of triply confirm that there didn't appear to be any metastatic cancer in my bones, which would dramatically affect outcomes and treatment. So we'll talk on that today as well. So I believe I met with the breast cancer surgeon on, I think, April 14th. Got a call the following week to book the appointment to see my oncologist on April 25th. So not too far out, which was good. The breast cancer surgeon said hopefully by the end of the month, and that certainly was the case. So in that intermediate week and a half there, really just tried to put ourselves in a brain space to get ready for the next step of our journey, and also to get as much sort of sorted and organized with the rest of our life as we could, because we knew we were looking at a summer full of chemotherapy. On Tuesday, April 25th, we drove down to Calgary, my husband and I, and met with my oncologist. She was absolutely fantastic. We also met with a oncology pharmacist to go over previous drugs that I've been on, drug complications, the drugs that I'd be taking with her lovely nursing team. Everything about that meeting was great. And the information that we took home, importantly from that meeting, was that first, she said just assume your scans will be fine and that you are looking at having a stage 2B breast cancer. So, not stage 0 or stage 1, but stage 2B. So with breast cancer, it's staged from 0 through to 4. So stage 0 being that ductal carcinoma in situ that is not trying or has not tried yet to evade the ducts of the breast. Stage 1 is quite small and locally contained. Stage 2 kind of can go one of two ways. So on one path down stage 2, your cancer is smaller than 5 centimeters, the tumor, but has maybe invaded into some local lymph nodes. On the other path, your tumor is larger than 5 centimeters, but does not appear to have invaded into local lymph nodes. And so that's what put me into that stage 2B category, because my lymph nodes appeared clear from radiology, but my tumor, and again, the oncologist sort of confirmed what the surgeon was saying, that it's uncertain whether it is sort of a large sort of mass with distinct regions that are showing up radiographically, because it palpates like a larger mass, but it was 4 sort of distinct regions on the radiographic imaging. But we're looking at something bigger than 5 centimeters, but not, luckily, invaded into my lymph nodes yet. Now, with staging, it is always something that can progress, right? So if they go in for surgery and they find positive lymph nodes, then that would potentially change your staging. You read a lot online about people sometimes feeling that there has been a bait and switch on the staging of their cancer. We looked initially and called it a stage 1, but then we did a biopsy or we did more imaging and found it to be a stage 2. And then again, certainly if the bone scan or the CT had shown metastases outside of my breasts, that would automatically bump you into a stage 4 cancer. But looking at stage 2B is still well within the very optimistic outcomes for cancer. Just looking at a statistic here, 5-year survival rate for stage 2B breast cancer is 95.6%. And that's according to data published by the American Cancer Society Journal in 2017. So greater than 95% 5-year survival rate, which means the goal of my cancer is to treat and cure it. Hey, editing Sarah here. Spoiler alert, we shaved all my hair off since I filmed that video. But I should say that 95% statistic is a statistic that encompasses all stage 2B breast cancer, regardless of subtype, regardless of your age at diagnosis, regardless of genetics, etc. My number is probably closer to 80% 5-year survival rate, and that comes from a very useful tool if you or someone you know is facing a breast cancer diagnosis, and I will recommend it here. It's called Predict Breast or Breast Predict. If you Google breast cancer predict breast, you will be taken to a site from the UK that is a sort of ratified by extensive study endorsed by the American Joint Committee on Cancer. And what they did was they looked at data, a very large data set of breast cancer patients. And you can go into the tool and you can put in your specific age, your staging, your ER, PR, HER2 status, the size of your tumor, if you detected your tumor through symptoms or through routine screening, etc., 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 including, sorry, the treatment options that you are choosing. And it can spit out a statistic that is more tailored to your specific cancer scenario. And you can also see, for instance, what your 5-year survival, 15-year survival looks like if you choose surgery only, if you choose surgery in combination with chemotherapy, if you are doing older chemotherapy forms versus newer generation chemotherapies, etc. So very handy tool. I will put the link in the description below. Like I said, that 95% is an umbrella statistic. HER2 cancers can be a bit more aggressive, but are luckily there's many more targeted treatments available these days. So anyways, Breast Predict or Predict Breast, link into the description below. Very handy, individualized tool for predicting your outcomes if you're facing breast cancer. So your oncologist manages your medical cancer treatment, not your surgical cancer treatment, and that would include chemotherapy and or radiation. And right now, what we needed to know was what would chemotherapy look like for me. The surgeon suggested it was likely 6 rounds surgery and then another maybe 10 rounds, and she confirmed that. So the drug regimen that I'll be receiving and have already received 1 round of is sort of, if you Google TCH online, that's how you'll find it. And it is a combination of 3 drugs. The T stands for Docetaxel. This is a cytotoxic, so cell-killing drug that is targeted specifically at cells which are actively dividing. So cancer cells, which are dividing at a faster rate than the rest of your body. But this is where the host of side effects from chemotherapy come from, because the cells that line your mouth and your intestine and your hair and your fingernails, like there's a lot of places in your body with active cell division or higher than usual cell division, right? So the docetaxel, like I said, it's a taxane type drug. I think they were originally discovered from yew plants, like yew trees, which are toxic. And they function by, and if you roll back the clock to maybe your grade 11 or 12 biology, you might have learned about mitosis or cellular division. During mitosis, you have a structure that forms in the cell called microtubules. And they need to reorganize and sort of make a network to help pull those cells apart. And the docetaxel binds up the microtubules and sort of freezes it so that they can't reorganize. They can't actually facilitate the pulling apart of the 2 cells during cellular division. And as a result, the cellular division fails, the cells die, and you don't have further cancer growth. So that's drug number 1. And it's been around, it's an oldie and a goodie. It's been around since 1989. It's listed as one of the essential, I think it's like on the World Health Organization, essential drugs. It's a standard cancer drug. The C of my T, C, and H is Carboplatin. This is basically just a compound that houses a platinum molecule. This drug is also cytotoxic or cell killing, and again targets cells which are going to divide. And so you get all those lovely side effects with this one as well, in addition to the very grateful job of killing cancer cells. And this one, in brief, works by producing some really reactive platinum compounds within your cells that then bind up your DNA and cross-link it. So in order for cells to divide, you need to duplicate the DNA within the cell before it can divide. So each cell has a full copy. That DNA synthesis process, if you have all these reactive platinum molecules coming in and sort of cross-linking and junking everything up, you can't have effective duplication of your DNA. If there's no effective DNA duplication, then there's no cell division. So my first 2 drugs are the standard systemic chemotherapy drugs. They're not specific to breast cancer by any means. They've been chosen because they seem to work well enough or better in breast cancer maybe than some other drugs. There's a whole host that can be very variable, I think, which sort of traditional cytotoxic chemotherapies you might get. So for me, we've got the docetaxel and the carboplatin. The H is the specific one for me. So because my cancer is the HER2 positive variety, I get to benefit from a new modern class of drugs, and these are antibody drugs, monoclonal antibody drugs, so very specific to my cancer cells. The Herceptin has been around since 1998. and really revolutionized the way that HER2 positive cancers can be treated. So if you recall, we talked about last time that you can have estrogen receptors driving your cancer growth, you can have progesterone receptors driving your cancer growth, or you could have this HER2 receptor driving your cancer growth. Human epidermal growth factor receptor 2. It doesn't actually collect a ligand the way that a normal receptor would. So on a cell, you might have a receptor and then you might have a molecule that binds into it. What this one does is you have some on a cell, and if it comes into contact and dimerizes, so forms a unit with another copy of itself, then it activates and signals. So on cells that are not actively dividing, or cells that are not overexpressing this protein, they're few and far between, they don't dimerize, and they don't initiate cell division. On my cancer cell, it's expressing too many copies of this protein, so there's lots of opportunities for that form, for two of my HER2 proteins to dimerize and to signal downstream. And once it signals downstream, it drives up cell division, and it also inhibits some of the processes in the cell that allow cells to die when they shouldn't be dividing. So it turns down cell death and turns up cell division and really drives cancer growth. The Herceptin antibody is going to come, and it's been designed to specifically bind to and react with the HER2 protein on my cells. And once it's bound on, it inhibits that dimerization, that forming of the complex that's needed for the signaling. As a result, it blocks that cellular proliferation. The nice thing about the Herceptin is that it is specific to cells in my body which are overexpressing that HER2 protein. So it should seek out in my breast, but also disseminated cells in my body that have this protein. Since most cells don't overexpress HER2, it should have less side effects. It can potentially cause some cardiovascular side effects. Those are reversible once you stop treatment. So that's my little spiel on how my understanding, and this is really brief. I mean, you can find this information just through really the Wikipedia pages even for these drugs, but just a brief mechanism how these drugs are going to do the job that they need to, which is to get rid of every last cancer cell within my body, hopefully. So T, C, and H would be the 3 drugs that I would receive. And maybe a 4th one. So we also discussed a P at the end of my regimen, so TCH-P. That P is for pertuzumab, or Perjeta is the brand name. It's similar to the Herceptin. It's an antibody drug that is specific to that HER2 protein on my cancer cells. It binds in a different region on that protein, and it can prevent it from dimerizing with itself, but also with similar copies. There's a HER3 as well. So it's newer. It's, I think just 2012 was initially when it came out, and the studies, long-term studies on it are still sort of rolling out. Similar side effect profile you would expect to the Herceptin. It's not currently approved for coverage in Canada, and antibody drugs are enormously expensive. And because this one is new, there is no biosimilar or sort of generic version yet. So we are exploring and making decisions on how we're going to proceed or not proceed with the pertuzumab. Editing Sarah again. In short, I will be receiving, or should be receiving, Perjeta, pertuzumab on Saturday, at some significant financial cost to us, but luckily for our family, not a financially crippling cost to us. There is a program that we enrolled in from the pharma company that produces the drug, where they offset up to 60% of the cost of the drug. And I've got feelings about that. It's a frustrating thing to know that because of our financial security, I am able to receive a drug that may increase my chances for good outcomes that would not be accessible to other patients potentially sitting right next to me with the same diagnosis. But with a public healthcare system, decisions get made sometimes, and this Perjeta, it's in short, the science shows that it does a great job at shrinking your tumor initially, and it's a sliver of an increase in long-term survivability, but it's cancer, so you don't want to fall into that gap where you might have benefited if you can afford the drug, right? So unfortunately, here in Canada, it's not currently covered by our healthcare, but at least there is a program to reduce the cost significantly, but it is still an antibody drug. It is still quite expensive. In the UK, it would be covered. I believe they initially did not cover it, and then they flipped that decision, and so it would be covered, I believe, in the UK. And I believe in the US, the recommendation is for insurance companies to cover this drug. Yeah, little niche areas of the Canadian healthcare system where potentially life-saving drugs may not always be financially covered by our umbrella. But I'll still take my Canadian healthcare system any day of the week. Anyways, that's all I'm going to say about that, but should be receiving that treatment on Saturday. Oncology appointment. We knew TCH, and I've given you a spiel over the drugs. We knew the pertuzumab, and at the time of that appointment, we didn't know that it wouldn't be just paid for. So that was a letdown that came on Friday when we got the phone call that said, no, it's unfortunately not actually going to be paid for. But we knew TCH, and we knew that we were looking at 6 rounds of what are called neoadjuvant treatment. So adjuvant is like in addition to surgery, the chemotherapy is going to boost your, outcomes in addition to surgery. Neo before. So before surgery, we're going to do 6 rounds of chemotherapy every 3 weeks. And then after surgery, another, I believe, 11 or 12 rounds of chemotherapy every 3 weeks. The after surgery rounds should only be the antibody drugs. So whether that is Herceptin and pertuzumab or just the Herceptin, we don't know yet, but it should just be the antibody drugs, which means that my hair will get to grow back and that I hopefully will be less sick. But still IV intravenous transfusions every 3 weeks and a drive to Calgary every 3 weeks. That's what we took away from the oncology appointment. The other major thing, and again, this was on Tuesday, the 25th, we asked how soon can we get started. She said as early as Saturday. And we said, sure, let's do this. Let's have 4 days and start chemo. Because there is nothing that we were waiting on to hold off on starting chemo. I should say that the reason we are able to jump directly into starting chemo is mainly around fertility. Like I said at the beginning of the video, I'm already a mom of 3. It's not important to me to conserve my fertility post chemotherapy. They can't give you any hard and fast rules on what the effects of chemotherapy drugs will be on your future fertility. My oncologist said that it's likely but not guaranteed that your periods will stop during chemotherapy treatment. They may or may not return afterwards. There may or may not be damage potentially to some of your reproductive systems that could affect your ability to conceive after chemotherapy. This is why you'll see it's very common, especially for younger men and women, to make choices about banking or saving fertility for after chemotherapy, right? So because we're happy with our family and it's not a concern for us to preserve fertility, we didn't need to go and do like a cycle of IVF prior to chemotherapy or a round of harvesting eggs. Or, I mean, for men, it would be a little bit easier, just, some sperm donations in the bank. So we are able to jump directly into chemotherapy. Other considerations would be if you were breastfeeding, if you were pregnant, you might postpone chemotherapy. I mean, all of those things would be counterindications. And of course, if you were sick prior to chemotherapy, you would want to start feeling well. So anyways, she said Saturday would be the earliest we could start, and we said, let's go ahead and start chemotherapy on Saturday. That was Tuesday. On Wednesday, I went for some blood work in the morning. Prior to each round of chemotherapy, I'll need to go have blood drawn to take a look at my total blood count, to look at my liver and kidney enzymes and things like that, and to most importantly look at my immune cells. Chemotherapy, like we said, kills quickly reproducing cells, and one of those places is in your bone marrow where you're pumping out white blood cells to keep you safe from infections. And so prior to each IV round of chemotherapy, you need blood work a couple days before to make sure that your baseline blood counts are high enough that you're not going to go dangerously low with the subsequent chemotherapy. So every 3 weeks, I'll have blood work a couple days prior to my chemotherapy appointment. Then I went for my bone scan on Wednesday. A bone scan was kind of very interesting. I've never had one before. The way that the bone scan works, it's sort of like one of the few things in imaging where instead of radiating you or sort of putting you in the machine, you are the signal and it's just capturing it. Does that make any sense? Let me explain. So what they do in the bone scan is they inject you into a vein with a very tiny amount of a very minimally radioactive tracer. In this case, it was technetium, and I'm probably not saying that perfectly right, but technetium 99M. So a very tiny amount of a radioactive tracer. They say that the amount that it emits is like less than getting a single X-ray. Once it's in your vein, you are not radioactive to the people around you, but you're ever so slightly more radioactive than normal. Then you walk around for 2 hours, and during that time, most of it will be excreted through your kidneys and into your bladder, but some of it will be uptaken into your bones. And the places in your bones that it will be uptaken are places that are metabolically active, so places that are growing, dividing, cellular repair. They'll ask you beforehand if you've had any recent breaks or injuries, because if you had, for instance, a fracture that was from 6 months ago on your femur, well, that's going to light up like a light bulb because that area would be still metabolically active. It would uptake more of this tracer. The bone scan is then you lie in a machine and very slowly, and the machine's not doing anything. It's just a detector. You're irradiating up to that detector. It detects the amount of signal, and you can actually watch it on the screen as it slowly populates a picture from your head down to your toes of your full skeleton, and looking for places of unusual metabolic activity. Luckily, and I will fast forward, we got the results Friday afternoon. My bone scan was clear, did not show any sign of metastases. And I can't verbalize enough or correctly the massive pressure that came off of my chest in getting that result back. Because leading up to that bone scan, every little sore hip, sore knee, sore anything was in your head 100% more cancer, which would dramatically change my outcomes. So incredibly grateful that it showed no signs of bony metastases. It did, interestingly, show evidence of my shin splints from overuse injury of running. And additionally, like I said, it gets excreted primarily through your kidneys. And since I've had a couple kidney stones, as I was watching the scan, you could actually see one of my kidneys lit up a lot brighter than my other because the urine pools in it and doesn't drain as fast from it. So I kind of have like one lazy, slow kidney maybe there. But again, just the take home on that bone scan was, thank goodness, no bony metastases. That was Wednesday. On Thursday, and you can see my week before chemo got very busy very fast. On Thursday, I had to go in for a echocardiogram. Again, earlier I had mentioned that those antibody drugs can be cardio, not toxic, but they can bind up some of the blood vessels around your heart and can potentially cause cardiac effects, including sort of in an extreme case, cardiac failure. So they need a baseline assessment through an echocardiogram of your heart function. And I'll go, and I'm not clear, I feel like it's every 6 weeks to 2 months throughout my full treatment for follow-up cardiac monitoring, just to make sure that we're on top of it. The nice thing about those drugs is it does appear that that effect is reversed if you stop treatment. So the idea is monitor throughout. If you run into any trouble, you can slow down or back off on the treatment, because obviously treat cancer, number one. Number two is don't succumb to any side effects, right? So echocardiogram is really not invasive at all. They put a couple of ECG leads on you, and the rest is just done with an ultrasound to look at the structures of your heart as well as the blood flow through your heart. So that was all done and good. I didn't hear anything back from my doctors, so if you don't hear anything, assume normal, right? And then Friday night, we got the bone scan results on Friday. We closed on some big projects in the rest of our life on Friday that took a ton of stress off my plate. And importantly, my family arrived. So we live out here in Alberta, and my parents hopped in their car once they knew we were starting chemotherapy on Saturday to make sure they were here for me. So they arrived Friday night. My brother and his girlfriend, who are in Alberta actually, also came for the weekend. So we had all hands on deck to take us into the first day of chemotherapy on Saturday. And it meant a lot to just be surrounded by the people who love me before embarking on this scary, but now especially the feelings now that we have some of that existential dread relieved, knowing that we're not looking at stage 4 currently and hopefully ever. So having that existential dread relieved and having just, there's an empowerment. We're started treatment now, right? It's not I have cancer and it's growing in me and we're not doing anything. I mean, as crappy as I felt the last couple days, those drugs are in my body, and for better or for worse, they are fighting this cancer. So yeah, Friday night just was a good night. I didn't sleep because, still anxiousness about starting chemotherapy the next day, but it was a good night and made so much better by my family's arrival, by some gifts that family and friends sent out for me, and just, cancer is a fight for a reason, right? Like it's described that way for a reason, and you need your support team to do that fight. So that's that. Anyways, hopefully this long-winded ramble wasn't too boring or too much. I will leave off here, and I will talk about round 1 of chemo in a separate video entity. And maybe next time you see me, I won't even have any blue hair. Thanks for watching.